Bismillahirrahmanirrahim. Assalamu alaikum and good morning, everyone. Welcome to the session on aesthetic dentistry. From today, we are going to start off with the posterior aesthetic procedures, which includes the class 1 and class 2 and class 6 lesions. So we are going to discuss all these individual procedures separately. As with any therapeutic treatment, proper diagnosis should be attempted before any course of treatment. Although the etiology of a specific tooth discoloration may be difficult to recognize, as we discussed in our previous session. We have various types of treatment modalities, which depends on conservative aesthetic procedures as well as non-conservative aesthetic procedures. Including the conservative aesthetic procedures, we discussed two categories of treatment modalities. Number one is the non-invasive treatment procedure, in which we are not supposed to use any high-speed turbine, but rather it's by definition is a non-invasive type of treatment. And then followed by minimally invasive, in which we are reducing the tooth structure in microns, let's say between 300 to 400 microns. So these kind of procedures, we call it as minimally invasive conservative aesthetic procedures. So including the invasive aesthetic procedures, we are going to address all these clinical conditions individually. Talking about the indications of class 1 composite restoration, there are some absolute indications whenever doing an occlusal composite restoration. Small and moderate restorations, preferably with enamel margins. Most premolars or molar restorations, particularly when aesthetics is considered. A restoration that does not provide all of the occlusal contacts, or a restoration that does not have any occlusal contacts. A restoration that can be appropriately isolated during the procedure. Some restorations that may serve as foundations for crowns or core buildup. Some very large restorations that are used to strengthen the remaining or weakened tooth structure in situations whenever there is some economic concern with the patient. When talking about the contraindications of the composite restoration, when the operating site cannot be properly isolated. Okay, the isolation is the most important part of any composite restoration. Whenever there is some kind of heavy occlusal stresses in patients with parafunctional habits, when there is all the occlusal contacts are only in the composites. And poor oral hygiene is also one of the contraindications of using composite restorations. When talking about the advantages of composite restoration, we know that all composite restorations are aesthetically pleasing, or tooth-colored restorative material, and there is conservative tooth structure removal. We do not remove with the concept in mind that extension for prevention, which was described by G.V. Black. Rather, we just remove the lesion part only. It's comparatively easier and less complex tooth preparation. It provides insulation, decreases the micro leakage, and there are some added benefits of the bonding system itself. For example, decrease in recurrent caries, decrease in post-operative sensitivity, increase in retention, and increase in the strength of the remaining tooth structure. When talking about the disadvantages are mostly related to the material, or if you are not using a recommended material, there is a greater localized wear. If you are not using in the described manner, there will be some polymerization shrinkage effects. If the material is not good, there could be some linear coefficient of thermal expansion, and the biocompatibility, including BIS-GMA of some components, is unknown. It requires more time to place as compared to amalgam. It is more technique sensitive. You need etching, priming, and adhesive placements, inserting the composites, developing the proximal contacts, finishing and polishing, and in comparison to amalgam, it is expensive. Okay, let's discuss with the clinical techniques of class 1 composite restoration. The initial clinical procedure the first and the most important step is the shade selection. The shade of the tooth should be determined before the teeth are subjected to any prolonged drying, because dehydrated teeth become lighter, brighter in shade, as well as they decrease in translucency. Minor or no tooth preparation may be necessary to clean the operating site with slurry of pumice to remove the biofilm, plaque, pellicles, and superficial stains, and sometimes the calculus removal is also important. Knowing the prep of the occlusal relationship is paramount for optimum restoration. After that, we provide the local anesthesia. Why? Because it's more pleasant and uninterrupted procedure. And there is a marked reduction in salivation as well. Isolation is extremely important for a successful composite restoration. Although with cotton rolls and other means of indirect isolation, a composite restoration can be performed, but it is highly unpredictable. The next part comes with the tooth preparation, in which we are only going to remove the faulty tooth structure, not extension for the prevention, as G.V. Black described. And we also create a convenience form in order to place the composite in more recommended fashion. The retention of the composite restoration is always obtained with the help of bonding.
Guys, let's discuss a clinical case of class 1 composite restoration. As you see that it's lower mandibular molar. The main complaint of the patient was that he is unable to masticate with that tooth, and he is true in that regarding that thing, because the occlusion is flat, and you know that in natural molars occlusion is never be a flat thing. It always have cusps and fissures in the grooves that helps in mastications. So we need to restore that tooth as natural as possible, so that patient can masticate as we are doing with our natural dentitions. Guys, as you know that before start of the procedures, we need to record the occlusions, as patient occlusion has been changed by a previous dentist. So it might be possible that to maintain the natural occlusion would be difficult in such cases. So first of all, we have to record the occlusal spots where a patient actually masticate, and that can be done with the help of an articulating paper. And remember that to recall these records, we need to photograph it, so that when we just doing the occlusion in the final thing, so we know how to maintain all these previous records in the final restoration. So this thing is very important. So you have to know where the masticatory spots are coming, so it will help you a lot in the final adjustment of the occlusions. Then the thing comes is which burr we have to use to make a cavity. It's a round burr, obviously it's a round burr, but it can be a diamond, it can be a carbide. So it depends on the preference, but my recommendation is for the beginners that you must use a round diamond, because it is easy to control it and easy to have a good grip on that thing. But in carbides, you can grind the tooth in a minute. So try to get some training with the carbide, then use it in your cavity preparations. But for that thing, you can use a round diamond right now. So it's a good burr. Then the next thing is to prepare a cavity, and in that case I used a round diamond and a small burr I used with air and water spray. And why air and water spray? So that we don't need to dry the dentine, as dentine has a lot of water and has collagen, has a lot of dentine tubules as well. So once you dry it, dentine throw away all the water, and that leads to sensitivity. And the most frequent complaint of the patients with the composite is sensitivity, post-op sensitivity. So that's how we can manage this problem. So we don't have to cut the tooth in a dry situations. We have always used air and water spray, so that we try to cool the dentine, so water remains in its position. Then come towards the etching. As you know that enamel is a different substrate and dentine is a different substrate. So we need a separate systems for both of them. As enamel is more mineralized, has less water, has no collagen. So we use a total etch. It's the strongest acid. and we can wash and dry the enamel. There is no problem with that. But when it comes towards the dentine has a lot of water in the collagen, so we don't need to dry it. We need such a system that can actually etch and bond it, and don't need to wash and dry it. So for that thing, self etch is the best thing in that dentine etching and the bonding. And it's also a system that limits basically post-op sensitivity. There is no post-op sensitivity when you use self etch system. So guys, total etch for the enamel and self etch for the dentine, and the time is about 20 seconds. And total, as you know, 37% phosphoric acid is a very common thing. It's available in the market. It's the most common thing you can find in any clinic. So then you have to apply the adhesive. As in self etch, the etchant and the bond in one tube, but in total etch you need a separate adhesive system when you are doing etching and bonding to enamel. So you can use self etch in enamel after doing a total etch. So the important thing is that when you apply adhesive, you have to apply 2 to 3 coats so that it can cover all the dentine tubules. It can basically lubricate all the dentine, and there is no area left where the adhesive is not going there. So you have to follow it. Then you cure it for about 20 seconds, and before curing you need to dry it a bit so that you have a very thin layer deposit on the tooth surface. Then the most important thing is how to fill the box before going to make occlusion. The best thing in this regard is you have to apply a flowable about 1 mm increment at the base. Why flowable? Because it can flow everywhere. It can adapt well. And you can see in the picture that there is no voids in the bubbles, and there is no shrinkage, there is no debonding. You can evaluate everywhere. So then you have to build the remaining box of the cavity in 2 mm increments. The basic purpose of doing 2 mm increments is to avoid polymerization shrinkage. And guys, when you try to cure it, you always increase the intensity of light with the passage of the time. Because if you use a high curing light, high intensity curing light, it will lead to shrinkage, it will lead to sensitivity. But once you use a curing light that increase intensity stepwise, so you can avoid the polymerization shrinkage and the post-op sensitivity as well. So in that picture you can visualize, when you see your restorations from the lateral view, that there is no gap, there is no shrinkage, and it adapts well. When you have such a beautiful adapted restorations, then your patients never complain about sensitivity and never complain about dislodgement of the filling. So you have to do this thing, but for that you need a magnifications. What we are using in clinics, we don't have magnification, so we have no idea where the composite is going, where the flowable is going. So you need a magnifications. For that you need a training with a magnifying lobes and microscope, etc. Then this is the pizza technique basically, and as we know the pizza, there are a lot of slices in the pizza, but they're equal in sizes. So the way we are going to build this molar in a pizza way, but the slices in the molar is not similar. God has created the molars in different slices. Every cusp has a different mass, different size, different volume, and different morphology. So first of all you have to read the morphology, then you can mimic in your restorations. In mandibular molar you have 5 cusps. The biggest one is a mesiobuccal, and then you have a mesolingual, then you have a distolingual, then you have distrobuccal, and then you have a distal. The most easiest cusp to model is a mesiobuccal one. Keeping the anatomical landmarks in mind, you just take an increment of the composite and then place it along the cusp and model it with your spatula, and you can use a bit of modeling liquid so you can adapt the cusp in a good way, but don't increase the volume. As written in the morphology, it's the most uniform and most easiest cusp to model, but we have to study the anatomy before doing this. Then the next cusp is distrobuccal cusp. It has a proper shape, it's a triangular shape, so you cannot adapt it in a rectangular way. So the limits of the cusp you have to keep in mind. You cannot extend the composite or the curves to the neighboring ones. You have to maintain the margins, and that's only possible with the proper training. And don't have to over contour it. You have to align it along the walls, never above the walls. You can see the margins are very clear here. There's no overhanging composite. So you keep in mind, and then you can do that thing. Then the next is the mesolingual and discolingual. Both cusps are modeled at the same time, and but that's only possible if you have a grip on that thing. But for the beginners, you have to do in a stepwise. So and then you have to cure it. Obviously, every increment need at least 20-second cure with your light cure machine. So cure it properly. You can over cure it even. There's no problem with that. There's no harm in that. So the only thing is that the curing light should never touch the occlusal surface. It's a bit away from the occlusal surface because it can contaminate the occlusion. It can contaminate the light as well. So, and the efficiency of the light will be decreased in after that procedures because you're doing a lot of things in clinics. Then you complete the modeling. The distal cusp is the easiest cusp. It's the smallest cusp, so you can complete the modeling, and then you can evaluate that there's 5 cusps there, and every cusp has the morphology that we studied in our anatomic books. So follow these things and do that things, but after reading the exact the morphology and the volume of the cusps. Then the next thing is finishing and the polishing. After doing restorations, the most important thing is how to finish and polish it, because finishing and polishing, without finishing and polishing, your restorations cannot live much longer, and it can attract the strain, and the food can deposit over there, and at the end you will end into discolorations and the poor restorations, and restoration will go away. So finishing and polishing is a very important and mandatory step, and for that you also need a training. But I'm telling you that for the external surfaces of the finishing, you need a disc here. That's a coarse disc to remove the excess composite over the cuspal margins, because if you don't remove it, the patient might have the bad occlusions. He can complain that occlusion is not right, he cannot masticate, and if he goes home with that occlusion with overhanging restorations, then the next day he will come with the pain. So you have to finish the excessive composite on the walls and everywhere. Then the internal surfaces of the restorations is finished with the finishing diamond, and in a very light and gentle way. You don't need to trim it. You have just to move it in a very slow speed, just to remove the overhanging composites there. So, and you can do it in a dry situation. There's no, because in a dry way, if you do it, you can visualize. If you use a water here, the details might be lost, and you might miss some things that need to be removed. Then before polishing, and you have to wash all the debris. If you don't wash it, these debris can accumulate in the fissures, and then it will just make a bad color to your restoration. So you have to wash it first. And now see how the restoration looks beautiful after finishing, even just after finishing, because you have a very uniform and smooth surface, and there's no roughness there. So once you have such surface, you will have a very beautiful polishing, and this polishing will never go away if you have such a finished and smooth surface. Then before polishing, you need a polishing paste. You can use a diamond polishing paste, and you can use whatever you have in the clinic, but important thing, you polish it. Just apply a bit of it on the tooth surface and spread it with a micro brush, and then take a polishing brush like goat wheel or some other, and then just polish it. So this polishing just make your restoration smooth and shiny, and gives the restoration a brilliant surface. So not even bacteria can adapt to that finish and polish surface. So try to do the polishing, guys. Then after completing all the procedures, you can visualize the first of all occlusal contacts. We recorded the same occlusal contacts in the previous initial picture. So you can see the same occlusal contacts we have in the final picture. It means we know how to record the previous contacts and follow these contacts in the post-op picture. That is only possible if you have a documented record, and that is with the photographs. So take the photographs and follow these photographic marks in the final adjustment of the occlusions. And about the tints, 90% of the cases have a stain fissures. So we just apply the tints here to make that molar as natural as human dentitions. Because yes, in few cases you don't see stain fissures, but 90% of cases there are stain fissures. And we have done a lot of molars in clinical practice, and every molar is stained except the few ones. So some patients ask me, some doctors ask me, sir, that looks very bad because you are just putting a brown tint in a fissure. Looks bad, but and might be we drill it, we consider it as a caries, but it's not a caries. It's just a stained fissure, and if you have an experience, you cannot make it carious. So carious lesions looks different. So that's why otherwise there's no benefit of doing such staining.
So in this image, we can see a previously placed amalgam restoration with creeped margins associated with secondary caries. You can also see the initial patent facial lesion on the distal surface and then secondary lesion around the amalgam. In such lesions, as you see that amalgam is looking worse in its appearance, and also the anatomy is not being goodly captured. Isolation is a first step. As you can see, the rubber dam is applied and the dam eversion is seen very beautiful in this. Without isolation, we cannot go with some excellent restorations in the modern era of dentistry. After preparing the cavity, the difference between the preparation of amalgam and the composite is that in amalgam we need specific depths, specific axial depths, line angles, straight floor. But with composites, we usually don't need any such preparation because the process of bonding is being accomplished as a different step. So we just need to remove the carious lesion with a round burr or a carbide burr, starting specifically with the high speed and ending with a slow speed handpiece. But that will control the cavity preparation. So this is the modeling. The modeling include, as doctors here very well explained, the different modeling steps like pizza technique, incremental technique, and the successive cusp built-up technique. You have to build the cusp step by step, and the successive cusp built-up technique. In the incremental technique, you layered it within increments. This is the post-op occlusal records to see either the restoration is high or it's an occlusion. By changing the slight spots, you can change and you can play with the occlusion of the patient. So by maintaining these spots well in occlusion, the patient can utilize his teeth in the pattern he was using previously. Any spot is not a high spot. You can see a lot of marks in the pic, but these are not the high spot. A high spot is basically a bull eye mark that seems to be shiny in the middle, and from the periphery, it's been well colored by the type of articulating paper we are using. So every spot is not a high spot. To check your high spot, usually you are supposed to check your articulating paper once you occlude the patient's teeth. The articulating paper should have been pierced from a center, and you can see a shining spot on the patient teeth. And this is a control photograph after a week time when the teeth is well hydrated. You can see there is ideal color matching and the ideal shade is there, ideal sculpting is there, and the patient is well happy with this type of restoration. Looking for another case in which we are going to see the initial lesion. As you can see, there is break in the integrity of the enamel and the lesion is spreading in towards the DEJ level. By looking, it seems to be a very small cavity, but remember, enamel lesions are usually a V-shaped cavity with a V-shaped neck on the occlusal surface and the broad base towards the DEJ. When you start removing such cavities, they're going to grow bigger. Application of the rubber dam again. See the eversion of the rubber dam. It's beautiful. No seepage of saliva can be seen if you apply the rubber dam in the well go. Here we'll talk about the disclosing dyes. A disclosing dye is an agent which, when applied to a tooth structure, making anything visible that is foreign matter on the tooth structure. How it works, the mechanism of action of disclosing agent is that it works by changing the color of the dental plaque to that it contrasts with the white tooth structure. Dental plaque has the ability to retain a large number of dye substances which can be used for the disclosing purposes. This property is related to the interaction because of the polarity difference between the components of the plaque and the dyes. The particles are bonded to the surface by electrostatic interactions, proteins, and hydrogen bonds like polysaccharides. There are different dyes like we use in dentistry are from iodine preparations like fast green, erythrocene, basic fusin, and Bismarck brown, and there are many others. Remember at this point that when we are ever applying the disclosing dye, we are supposed to apply it for 10 seconds and then wash it thoroughly. After washing, if the dye retains in areas, these areas are meant to be carious. So you are supposed to clean these areas very cautionally, very under observation, so that we cannot remove the further area. Remove these areas in which the dye is sticked and then start filling. So here is the sculpting of the restoration, cusp to cusp built up. You can see the pits and the fissures, and every cusp has been defined beautifully separately. After the removal of the rubber dam, see the occlusal spots. These occlusal spots are mandatory to check for the occlusion. Remember, the functional cusp of the lowers are the buccals, and for the uppers they are the palatals. They retain the functional cusp will retain the vertical dimensions of the face.
Let's move towards the discussion what we have already discussed. So I have a very simple question. Why class 1 lesions are more common?
Because the class 1 lesion is on the occlusal surface of the mandibular molars, so there are the pits and fissures that are the nacre for any external particles that can be attracted with that. So what do you suggest, Dr. Zuhair? Do all the pits and fissures are the nacres?
No, Dr. Dilawar. You have seen a lot of mandibular molars and the maxillary molars. The pits and fissures, they are very smooth and self-cleansable. So it's not necessary that every patient has class 1 caries. Only those patients who have deep pits in the fissures, where there is chances of food accumulation.
You mean non-coalesced surface?
Yes, non-coalesced, where there's a morphological defects there.
When the lobes are unable to join together.
Yes, so in those cases, there are more chances of class 1. And the third thing is very important thing, because it's a surface where the patient try to masticate. So it's a surface where your brush bristles cannot reach the deep pits and fissures. So this is also a factor.
So how we can prevent the class 1 lesions to be formed, Dr. Kashif?
Pits and fissure sealants, or we can do some enameloplasty. So we can
make them
self-cleanable. If the food is getting stagnated on the surface, the carious lesion will start. If it is easily cleaned, there will be no carious lesion.
Dr. Dilawar, throw some light on enameloplasty. What is that procedure?
Enameloplasty basically is been done with smallest round burrs, like 1/16 round burr, to make the area self-cleanable. Basically, these pits and fissures are like the valleys between the mountains, and these valleys does accumulates a lot of materials from the food particles and any other chromogens in the diet particles. So we shall make them self-cleanable.
So it's a preventive procedure, basically.
It's a preventive.
Exactly.
Yes.
So the next question is, what is the pathogenesis of class 1 lesion? How the class 1 lesion starts? We know that inside these non-coalesced fissures, there is some food is accumulating, leading to bacterial biofilm, and which is producing the lactic acid, by which the mineral part is demineralizing. So beyond that, what is the pathogenesis? What happens?
The histopathology of the class 1 caries or enamel caries is divided into different zones, like translucent zone, darker zone, body of lesion, and the surface lesion, depending upon the pore size of the enamel. As the pore size increases, as we go deeper, the pore size increases, and the lesion get gross.
Moving to another question, Dr. Zuhair, what is caries disclosing dye?
You know, it was a very common practice that we always remove the infected and the affected part of the caries by just holding a burr and try to remove the soft caries. And even with the removal of soft caries, we remove the affected zone as well. So the caries disclosing dye is not a recent innovation. It's a dye available in the market. You just put it into your tooth surface where you want to remove the caries. And the best thing about dye is it just stains the infected part, the denatured collagen, and it spares the affected one where collagen is intact. It comes in pink color, it comes in green color, it comes in blue color. So whatever the color is available in the market, you can use it.
Kashif, what do you suggest about the color usage in enamel and dental caries?
In superficial lesions, it's important that we can use any color. If we can use pink or red color, it can be used in the superficial zone, but not in the deep zones, because it's going to be very difficult to discriminate between the pulpal exposure and the dye. So it is important that if we are going to use the disclosing dye, we use blue or green dye in the deep carious lesion to discriminate between the pulpal exposure.
Yes, and the mode of action is that it works by the polarity difference between the components of the plaques and the dyes, because anything that accumulates on the white surface shows us the polarity difference once we use the disclosing dyes.
Yes, and the procedure of application is you just take a micro brush and put some dye to the tooth surface and wait for 20 seconds and then wash it away. The area where the stain is, you have to remove that thing. But the area where there is no stain, that's affected part that can remineralize.
So, Kashif, can you name few of the dyes we used as a caries disclosing dyes?
We have bromine, we have erythrocene, and we have phos green. These are the three dyes which are available.
And others like Bismarck Brown and Marlboro and Basic Fusion.
And that is available in the market with the brand name of caries detector.
Caries detector. Yeah.
Yes, you can ask your technician to buy that thing.
So the next question is, what are the differences between amalgam and composite tooth preparation?
There is nothing similar between amalgam and the composite. Amalgam is aggressive material where you need a proper depth, proper width of the shape of the cavity. You just remove the sound to structure to get some undercuts. But in composite, you don't need all these things. You just need to remove the caries and you just bond the composite.
So can we say, Dr. Zuhair, we use amalgam for extension, for prevention, and we use composites for prevention from extension.
Yes,
Yes, you can. You're right. You're right. Because we are only removing the fault. For amalgam, we need a strict and specific geometry of the dimensions, like the depth. If the depth is less than 2 millimeter, amalgam is not going to survive. But if we talk about the resistance form, the resistance form is universal for any material. But whenever we are talking about the retention form, we know that the composite is being retained with the help of adhesive system, not with the undercuts. So we do not provide any undercuts in composite restoration.
So amalgam is a macro-mechanically retained material, and the composite is a micro-mechanical
Plus chemical
bonded material.
And the last important thing is color of the composite. Amalgam is a silver, dark in color, and composite is white.
And we have to condense the amalgam, like with a proper force, like
proper
5
force.
pounds.
You can feel it
You can feel it. And with composite, you just have to pack, and pack.
and just sculpt the way you want. So the next question is, which burr is recommended when doing a composite restoration?
Basically, we use a round burr. That can be a diamond, that can be a carbide. I discussed in the lecture, previous slides, that to control a carbide is a difficult thing, but to control a diamond is an easiest thing. It means you can use the carbides when you have a proper training on that.
So, Kashif, do you think that there is any advantage of using a diamond burr at the start of the preparation of the carbides?
If we are on the superficial zone, I think diamonds are more recommended because they produce a lot of smear layer, hence they are producing smear plug. Yes. But whenever we are in the deep carious lesion, we need to have some carbide burrs so that we can easily scoop away from all the
And if we have suitable time, we should move and start our preparation with a high speed, and at the end using a slow speed with a carbide burr that can control our preparation.
Exactly, you're right. Moving towards the etching and bonding technique, which is the most ideal for, is it a total etch, self etch, or selective etch? Which is best for class 1 composite restoration?
For enamel, we discussed already that enamel is highly mineralized structure. For that, we need a strongest acid, and that acid is only available in the form of total etch and selective etch. Selective etch means we just etch the enamel and then we need a separate system for dentin, and that is self etch. So for enamel, selective etch, and for dentin, self etch.
As Dr. Zuhair explained well about the total etch, so enamel is the hardest layer. So what etching is doing, it's just raising the surface area, it decreasing the surface tension so that the bonding agent will flow it properly. And the ideal standard for enamel generation is 4th to 5th generation, and the self etch is 7 and 8 generations coming in single bottle. That is difficult to handle because of the concentration of the water, and its shelf life is also a problem. Please add, Dr. Kashif, something.
6th generation is also self-etching, in which separate, the primer itself is acidic, so we don't need any separate etchant in the 6th generation. So it's advisable that whenever we are dealing with dentin, it's important that we should use the self-etch method rather than total etch.
Otherwise, with total etch, when we'll dry the surface, the collagen will collapse.
And the total etch system also removes all the smear plug completely, which leads to post-op sensitivity.
Yes.
The final question is, why composites tend to shrink more in class 1 cavity configuration? Since we know that we discussed in configuration factor or the C factor, that the class 1 has the highest C factor. Why? Because we have multiple bonded walls. And what is the mechanism of the shrinkage of composite? It always shrinks from bonded to unbonded surface. So if we have more bonded surfaces, there is a greater tendency of composite shrinkage. To overcome this, as you have seen during the description of Dr. Zuhair, he used a flowable. Flowable tend to shrink more, but it doesn't exert too much force on the surface. So it can easily adapt on the immediate surface of the tooth structure. On top of it, we can use any packable composites. So the configuration factor is most important, and it is determined by the cavity geometry.
And to avoid the class 1, we can use pre-polymerized resins, we can use silorin based composites, and we can also use the snow plow technique, like Dr. Kashif explained, like use the flowable in the base and then pack the packable in that, so that it can go into the voids.
At the end of the lecture, I want to say that this lecture is a team effort. I am very thankful to Dr. Kashif and Dr. Lover for their valuable time, and hope we will continue the same pattern in our future lectures.
Inshallah.
And we try to make it interactive. Anybody can give the lecture, but via this interaction, we can clear a lot of queries which come into your mind pre-hand. Whenever you listen to the lecture, you will be clearing a lot of queries which coming in your mind.
2 are better than 1 and 3 are better than 2.
Have a good time.